about the residential care. I guess just wanting to get some clarification. Like the first recommendation, it sounds like you're talking about crisis bed placements. Am I on the right track there? And then one of them talked about secure residential treatment.
Right. So the big value, I think, that people brought to the residential and long-term care sort of conversation was that that we see that when we got rid of a lot of the psychiatric hospitals, we really don't have as many places for people who need more than a short stay in a hospital, but less than, you know, heading to Caro for a couple of years. And so this idea of looking for those sort of medium-term almost placements, so somebody who might need 30, 60, 90 days of stabilizing care, right, to come out of crisis, to get their medications right or whatever. And what we're really considering there, which I think could be really interesting as an experiment, is that we might be able to do these more community by community, that in a lot of our hospitals that we already have, we might be able to use a wing of beds that are so people aren't being taken out of their community, and away from their family and their, you know, their positive influences, but be able to so it's basically that sort of medium term, this recognition that we don't really have any solution for that right now. The security issue is, for a lot of folks that are in, you know, residential placements, whether it's adult foster care or some other placement, right now, people feel like sometimes their hands are tied when somebody is, that was bad metaphor, I should not have said that way, I guess, for what I'm about to say, but I feel like they don't have very many options when somebody is just behaviorally becoming a challenge right now, and you don't want to medically sedate someone, you don't want to physically restrain someone, but you need them for their own safety and the safety of others with them to be segregated maybe away for a little while, or you need them not to leave for those folks who wander, so some of our folks with dementia and some of our older citizens. And right now in our codes, you can't lock a door. And so what we want to do is find a way to help, but it's got to be very narrow, it's got to be very careful, because we're not looking to have people imprisoned essentially, right, in some of these placements, but to be able to extend some security allowability for some of these placements, so that, again, it also just opens the doors for some people right now that can't have certain placements because their behavior or their diagnosis makes it difficult for them to stay there. So that's the goal, and it will be interesting. It's one of those ones that's going to need very careful policy crafting and very careful enforcement, right? So,
how does this look like or relate to the rural areas? Because, like, the community that I live and work in, the closest hospital is over an hour away. Mm-hmm. You know, and you talk about the behavioral issues. I work with individuals who we've had to send them to the other side of the state to even be to find appropriate community placement because of behavioral issues. How would, I don't even know if you'd know, what would funding look like for those rural populations, you know, or up in the UP too, to address those issues that can't be right now in the community or aren't there?
There's a real focus, and especially from that work group, on trying to figure out how we can strengthen the opportunities for folks to be in the communities where they are, even if they're rural, even if they're small communities. And so this kind of a recommendation it came, I think, with the intention of being able to expand the number of placements in a community, because if all of a sudden, even with the current infrastructure that you have, if you could take an additional set of patients, of clients, of citizens into your facility because you have that ability, then you can provide more care and keep people in their community. The other thing was that with a lot of our foster care and adult foster care right now, those placements, we don't necessarily have a place to keep siblings together. We might have one opening. So you see that as a recommendation that for any kind of residential placements that we prioritize putting siblings together, so reserving 2 or 3 spots in a particular home. So a lot of the intention is to get, I think, to exactly what you're suggesting is a need. The funding will be a question, right? But there was a real recognition that the needs of our more populated and less populated communities are different. And that while we want enough standardization that people who are up north or people who are out in the thumb deserve the same quality of care, deserve the same access to programs, should not get, sort of second-rate support. So we want it to be standardized in that way, but we also want it to be flexible enough to recognize that the needs of a rural community might be different, especially when it comes to, some of those placements, when it comes to transportation, when it comes to, some of the employment opportunities. So there'll be a focus on, and I think a couple of our pilots in particular will be in very rural areas on purpose to see what those additional supports look like, what those costs, either more or less, how does it actually play out, so.
I have a question. I noticed my son went to the hospital, and we have private insurance, and we noticed you're at a disadvantage to have private insurance in the hospital because he had to be discharged in so many days, whereas other kids could stay much longer, and he needed to be there longer. We couldn't apply for it because we're not eligible, and we just noticed this. Is there going to be anything to catch these people that are sort of caught? Basically it's terrible to have private insurance in this situation.
I think it's something that we are, that we're aware of. It's something that we see some opportunities with what's changing with the Affordable Care Act, honestly, and some of the changes to mental health coverage through what's required as the essential benefits like plans are unrolling. I don't know that we have all the answers yet, but one of the other things that I'm going to do for the next year as part of the Medicaid expansion bill, they put a group of us on a work group that's supposed to study healthcare costs and quality as a result of all these changes, and what other states are doing is an all claims payer database, right? So they're looking at things like, if you knew community to community how much it costs to get surgery, get a transplant, get your appendix out, whatever, you might make decisions about where to go in different ways. And what we're seeing in a lot of hospitals are really, people feel like really financially driven decisions about length of stay, about treatment. And we're going to be studying it for the next year. And I'm hopeful that, again, this is another place that we can just use the bright spotlight of that committee's work to show where these gaps are and to encourage people to have different policies.
One thing that occurs to me too, this is a bit like putting an earring on a pig. But in our family-to-family class, for example, we really try to teach resiliency skills. And boy, and those of you who deal with this, some of the parents and some of the care providers, they really know how the system works, how to game it, the good ones, and just on that, that comes up in our family-to-family a lot, and we say, well, do you know how to do the appeal process with the insurance company? And so, these are all, like I said, not addressing the root cause or the core issue, but they are some things that can be done.